It's now my great pleasure to welcome to the stage Chris Carroll, Managing Director, Health Insurance Bupa. He'll make some opening comments and he'll introduce the Minister. Thank you, Chris.
Good afternoon. Thank you, Jill. It's a privilege to support today's event as a member of the CEDA community, led ably by Melinda, participating in constructive policy dialogue and driving positive change on the things that matter most. Welcome Minister Butler and Assistant Minister Jed Carney, and fellow health sector leaders. Thank you for being part of the discussion today, focusing on building a stronger Medicare. I want to acknowledge that we are meeting today on the traditional lands of the Wurundjeri people of the Kulin Nation. I pay respects to their elders past and present, and I extend this respect to any First Nations colleagues here today or watching on live stream. I acknowledge the Wurundjeri people's ongoing connection to these lands and waters and the important role of First Nations people and organisations in the stewardship of our health system. And I know you're all eager, like me, to hear what Minister Butler is going to say about his vision and the Albanese government's vision for our health system and for Medicare. You only need to listen to stories from around the world to see how privileged we are with our health system, which is a testament not to luck but to political bravery and good public policy. In particular, it was the boldness of a past Labor government that established Medicare, and the attachment of Australians to it has cemented its bipartisan support. Successive governments of both persuasions have recognised that a universal health system required a strong and vibrant private health insurance scheme to increase funding for healthcare overall, promote equity, provide choice, and ensure that the most vulnerable Australians are able to access care. This hybrid system provides significantly lower gaps in healthcare outcomes between the rich and the poor than either the privately dominated US system or the UK's publicly dominated system. And at the centre of all these systems are people. Which brings me to a story that I want to share about one of our customers, Paul. A few years ago, Paul was admitted to hospital with a heart condition. His irregular heartbeat and racing heart caused him a lot of discomfort, and he was in and out of hospital with surgeries and checkups. Yet his doctors were not noticing any improvements. His cardiologist told him, "You don't have a lot of years left in you. Your future isn't looking good." For a man who was a championship motorbike rider and who had been fit for most of his life, this was tough news to accept. But now he has managed to give himself a second chance at life, and he says a new heart health program we are running with Ramsay Health Care has helped turn his life around. This heart health program saw Paul, who is 83 years old, equipped with technology and remotely monitored daily by cardiac nurses and allied health professionals. He was also given exercise and diet programs and coached to manage and improve his health. It's been 15 months since he has finished the program, and I'm glad to report he hasn't been back to hospital. He describes the program as a lifesaver. He's now exercising twice a day, has been able to push aside his walking frame, and has even returned to his line dancing classes. Now, why am I telling you about Paul's story? The health and well-being of Australians can be enhanced with reforms that put consumers first and make healthcare more relevant and affordable for them. The goal for all of us is to modernise healthcare to better meet patients' needs with digitally enabled personalised care. Looking back, in his first speech to Parliament, Minister Butler spoke about the importance of care that responds to people's individual needs. He spoke about using a social inclusion model to improve mental health care for vulnerable people in South Australia. It's heartening to see the Minister's clear-eyed purpose in managing our country's health system, building on his earlier experience as Minister for Mental Health and Ageing and Social Inclusion in the former Gillard government. And since coming to office again 18 months ago, we can see that he has set a fast pace for action. This has included action to improve access to healthcare and relieving pressure on household budgets with increased bulk billing incentives, lowering the cost of medicines, addressing smoking and vaping, and the establishment of urgent care clinics to take pressure off public hospital emergency departments. We all know the health system is under pressure and has been since the start of the pandemic. We also know that all health care begins and ends in primary care. And it's clear the Minister and Government have big ambitions for the future of primary care. We look forward to hearing what the Minister has to say today about future reform to Medicare to improve access and quality for the whole community. Can you please join me now in welcoming the Minister for Health, Mark Butler, to the stage.
Well, thank you very much, Chris, and to CEDA and the sponsors, Clayton Utz and Bupa, for pulling together today's lunch, and for all of you for coming along today to give me some gentle, probing questions about our plans in health policy. Can I acknowledge also that we're on the lands of the Wurundjeri people of the Kulin Nation and pay my respects to their elders past, present and emerging. And although she has been acknowledged, can I thank my Assistant Minister for Health and Aged Care, Jed Carney, for coming along today and for all the terrific work she does in health policy and has done for many years in different roles. Jed and I think what you'd kindly describe as in the back nine of our careers, having been around for a while. Kate Thwaites, on the other hand, is a leading member of a really exciting new generation of Labor MPs, and I'm delighted that she is the member for Jagga, filling very big shoes in Jenny Macklin's old seat, has been able to come along today as well. And to all of you, thank you for coming along. On this day, 18 months ago, Australians went to the polls and cast their vote, a vote that would end the Morrison government and 9 years of cuts and neglect to Medicare. Today, as we look ahead to the 40th anniversary of Medicare in February, I want to provide an update on the government's efforts to strengthen Medicare and to provide some reflections on the road ahead. It's no secret that when we came to government, general practice was at its most parlous condition in the 40-year history of our system. It had never been harder and never more expensive to see a doctor, and bulk billing was in sharp decline. Pensioners, concession card holders, families with young kids, all were being told that at the front desks of general practices everywhere, their visit was no longer bulk billed. Put the Medicare card away and pull out your credit card instead. The former government had been telling us that everything was rosy, that bulk billing was at an all-time high, a rate of nearly 90%, they said. But in this, the Morrison government was characteristically loose with the truth. It concealed the true extent of the decline in bulk billing behind a smokescreen of temporary COVID measures. Millions upon millions of bulk billed COVID tests and vaccinations, all of which had to be bulk billed, were artificially inflating the numbers. It was only once we were elected and I directed the department to report the statistics more transparently and more regularly that Australians began to see the true state of bulk billing. Once all of those temporary COVID measures were set aside, it was clear that bulk billing had been in real trouble for quite a while. In the year to June 2020, so the first year pre-pandemic, just over 67% of patients, so 2 in 3, had every single GP visit bulk billed. By the 2022 election, that had fallen to little more than 64%. For adult concession card holders, pensioners and other concession card holders, the fall was even more significant. The bulk billing rate had dropped by fully 5 percentage points from 2018 until the 2022 election. The true bulk billing rate, the one that actually told us whether Australians were paying gap fees when visiting the GP, wasn't 90% at all. It was more like 64%. A 6-year freeze to Medicare rebates that started under Peter Dutton was really starting to bite, and particularly started to bite as the global inflation shock swept through the Australian economy. And the impacts are still being felt today, with the bulk billing rate for the most common GP consultations continuing to decline, as data that we published early last week showed. But bulk billing wasn't the only area where cracks were showing. The signs of a system under strain were everywhere. As you all know, Medicare is facing a range of demographic headwinds. The population is ageing and chronic conditions are increasingly common. And as the College of GPs Health of the Nation report showed last week, more and more Australians are presenting to GPs with mental health conditions or seeking diagnoses for developmental disorders. Patients have increasingly complex needs that require the care of a team of health professionals rather than a single GP who might be working alone. Now, none of these headwinds are new, and a number of people in this room, indeed, have been sounding the alarm on some of these trends for many years. 50 years ago, 1/4 of the population had a chronic condition, only 1 in 4. But 15 years ago, that figure had climbed to around 40%. And 10 years ago, when Peter Dutton was sworn in as Health Minister, the ranks of Australians with a chronic condition had swelled to about half. And Australia is getting older too. The proportion of Australians, as you all know, aged over 65 has grown over recent decades, from 1 in 12 when Doug Everingham was Health Minister under Gough 50 years ago, to just 1 in 7 when Peter Dutton was sworn in. The demographic headwinds were reaching gale force, and the warning signs of a system under pressure were everywhere. But instead of taking evasive action to right the ship, Peter Dutton started to scuttle it, throwing the oars overboard and burning the life rafts. Because just as it is in Labor's DNA to strengthen Medicare, it is in the Coalition's to weaken and to undermine it. The Liberal Party has always had a deep ideological antipathy to Medicare, ever since Malcolm Fraser abolished its predecessor, Medibank. The father of the modern Liberal Party, John Howard, called bulk billing an absolute rort and threatened to pull Medicare right apart. When he was the Health Minister, Peter Dutton famously lamented that there were, in his words, too many free Medicare services, and began a program of cuts and neglect to deal with that. He tried to do away with bulk billing altogether by introducing a tax on every visit of every person to a GP. And when Labor and the Parliament blocked that, Peter Dutton and the Coalition froze the Medicare rebate for 6 long years, ripping literally billions of dollars out of our primary care system. And even though a record number of Australians were needing regular medication for their chronic conditions, he also tried to jack up the price of medicines by up to $5 a script. Is it any wonder, really, that Australia's doctors voted Peter Dutton the worst health minister in the Medicare era? What followed was a program of calculated neglect. Pilots were launched only to be mothballed by the next Liberal health minister, something the Grattan Institute has described as more pilots than Qantas. Recommendations from medicines experts were ignored. Strategies were announced with no funding to deliver them. And my health record stagnated, bungled and full of bugs, really old technology. And on the rare occasion that a Liberal health minister was prepared to deviate from neglect, they were usually blocked by their own party room. Like when my predecessor, Greg Hunt, to his eternal credit, introduced regulations to ban the import of vapes and e-cigarettes just as that market was beginning, he was rolled by his own party room in a matter of days, and the import ban had to be junked. And we've seen what's happened since. Another reform not implemented, more calculated neglect. Because here's the thing I think we all understand in health. Reform is challenging, and without political will, it's frankly impossible. So by 2022, as Australia went to the polls 18 months ago, Medicare was really taking on water, and urgent action was needed. That's why my immediate priority was to chair the Strengthening Medicare Task Force and to bring together representatives from across the health sector to agree on the road to reform. And in the May budget, we began to walk that road, delivering an historic $6.1 billion package to strengthen Medicare, including the largest ever investment in bulk billing that took effect only 2 or 3 weeks ago. This was a much-needed injection of funds delivered alongside more foundational reforms to enable the kind of multidisciplinary, team-based care that Australians today need. The tripling of the bulk billing incentive for more than 11 million Australians took effect on the 1st of this month, because for Labor, the bulk billing is the beating heart of Medicare. 5 million families with kids under 16 and 7 million adult pensioners and concession card holders will now find it easier to see a bulk billing doctor. These patients account for around 3 out of 5 visits to the GP, and in some communities much more than that, meaning a very significant increase to general practice income. For a doctor in a major city, the Medicare payments they now get to bulk bill those patients for a standard consult have increased this month by 34%. And for a doctor in regional and rural Australia, Medicare payments for that sort of consult have increased by around 50%. In the Hunter, Dr. Samara Singh said, "It's truly a lifeline." And in the Northern Rivers of New South Wales, Dr. Ken Stockley told us it's going to encourage those that have recently changed to private billing to go back to bulk billing. And even in these early days, only 3 weeks into the new incentives, that is exactly what we're seeing across the country. Clinics everywhere making that shift. General practices that were charging gap fees before the tripling of the incentive and have now shifted to bulk billing again for every child under 16, every pensioner, every Australian with a concession card that passes through their doors. And rural and regional Australia will benefit the most, since the incentives are considerably higher as towns get further and further away from the state's GPO. And as well, practices there often serve a patient cohort that is older and more likely to hold a concession card. The government's reforms to strengthen Medicare are changing the game across a whole range of areas for practices and for patients alike. A new Medicare rebate for GP consultations that are longer than 60 minutes became available for the first time on the 1st of November to give GPs the time they need to provide better care for patients with really complex needs. And in just the first 18 days, there have been several thousand of these Level E consults delivered already under Medicare. We've also given GPs the support they need to grow their nursing and allied health workforce teams by increasing the workforce incentive payment by up to 30%, and for the first time indexing it every single year. Since the 1st of July, this has provided a much-needed boost to the nearly 6,000 practices that receive the incentive, helping them support more than 21,000 health practitioners, including 16,000 nurses. Smaller practices that simply don't have the means or the market to bring on permanent staff will soon be able to call on services of nurses and allied health practitioners through a $77 million program of PHN commissioning and practice support. And I really want to see this program delivered by our primary health networks to innovate, to explore opportunities for them to try new things like social prescribing through social workers and the like. Then there are our cheaper medicines reforms, delivering the largest cut to the maximum co-payment in the 75-year history of the PBS, saving Australians more than $200 million in just 10 months. And that $20 million saving per month will continue into the future. We reduced the PBS safety net threshold last year, so more pensioners and concession card holders get free medicines sooner, reducing the yearly medicines costs for around 2 million older Australians by as much as 25% this year. And of course, a little controversially, delivering 60-day prescriptions for 6 million Australians with a chronic condition, with 600,000 60-day scripts already issued in just the first 2 months. These important cost of living measures in the area of medicines are not just good for the hip pocket, they're also good health policy. We simply can't strengthen Medicare for the 21st century without also strengthening the PBS. A 30-day script made a lot of sense when chronic conditions were rare and patients were usually attending their pharmacy with a short-term illness seeking a one-off course of medicine. A 30-day script makes much less sense today when half of the patients have a chronic condition, and many of them are on the same medicine, not just for years, but often for decades at the same dose or even for the remainder of their life. Cheaper medicines benefit patients with both their hip pocket and, we know, improve medication compliance, so improves their health as well. Patient benefit is what is driving Labor in all of these things. Take, for example, the upgrades to My Health Record. Only 1 in 10 specialists currently uses My Health Record, and just 1 in 5 diagnostic reports in radiology are uploaded. The other 4 just disappear into the digital ether. Patients find this so frustrating, as I know do GPs, because every lost test result means another day off work, another waiting room, another procedure, and perhaps another gap fee. What a complete waste of time and money and poor productivity for patients and for the health system. If a patient gets a diagnostic scan or pathology test, particularly when it's reimbursed by Medicare, then those results should be uploaded. At the moment, this happens by exception because it's not the rule. Well, I intend to make it the rule because, frankly, patients expect it to be the rule. Against that clear and compelling patient benefit, arguments that change is too hard or too expensive just aren't good enough anymore. Because building a stronger Medicare will mean change. Change like the introduction of MyMedicare. MyMedicare is the foundation upon which a stronger, more personalised Medicare is going to be built. Patients will get more tailored, quality care from their regular practice, their regular GP and health team. And practices will get better information about their registered patients. MyMedicare will help Medicare go beyond the limitations of fee-for-service, with a range of blended funding packages to help practices tailor care to patients from priority groups. It's still early days since registration opened on the 1st of October, but already nearly 370,000 patients have registered, along with more than 5,000 general practices. And the benefits of this system-wide reform will grow over time as more patients and more providers join. The first 2 blended funding packages will become available in the middle of next year. One will be targeted at the more than 13,000 patients that present to hospital 10 or more times in a given year. And the other will be targeted at the nearly 200,000 Australians in residential aged care. Practices registered for MyMedicare will be paid incentives to provide their registered patients in aged care with regular visits and care planning. The development of the funding package for that group has been worked through with stakeholders and can now be announced. The incentives include $300 per patient per year to be paid quarterly to the GP, him or herself, and $130 per patient per year to be paid quarterly to the practice. Rural loadings will apply, with payments increasing in line with the remoteness of the community. And importantly, these funding packages sit on top of the existing fee-for-service. They don't replace it. All existing Medicare rebates for those services will continue to be paid as well. As well as strengthening the funding structures that enable health teams to do their important work, we also need to support more health workers in those teams to actually do that important work. Professor Mark Cormack's Unleashing the Potential of Our Health Workforce review will find the opportunities for everyone in our highly educated health workforce to provide every single ounce of care that they can, because that will also free up our doctors to focus more on the complex conditions that only they can treat. The first batch of consultation took input across the health sector, with more consultation opportunities next year before the final report is delivered by Professor Cormack in about October. I'd like to see every health professional work to the top of their skills, their training and experience, but we particularly need to break the glass ceiling that has held back our highly educated nurses and nurse practitioners. When I was Jed Carney pumps the fist. When I was last in the health portfolio under Julia Gillard, there were around 2,000 nurse practitioners in Australia. And 10 years on, and there are still 2,000 nurse practitioners in Australia, and maybe 500 or 600 of them aren't even able to get jobs as nurse practitioners. In the budget, we announced that we would raise the Medicare rebate for nurse practitioners by 30%. We would remove the legislated collaborative arrangement requirements that continue to restrict their autonomy, and would build that workforce with a large scholarship program. But we can't kid ourselves. The global health workforce crunch is not going to be solved overnight. While part of the solution will be in changing who Medicare supports to deliver care, the other part will be in changing how and where Medicare supports them to deliver the care itself. Because the modified Monash model, the system of district of workforce shortage and distribution priority areas, these levers that we currently have to spread doctors and health workers around the country are from a very different time, before the COVID pandemic and before the global health workforce crunch. Which is why we are going to undertake a wide-ranging review to urgently investigate how to more equitably distribute doctors and other health workers across the country. The Working Better for Medicare review will look at how current policies and programs can be strengthened to make it easier to see a doctor, a nurse or other health worker in the outer suburbs of our major cities, as well as obviously in regional, rural and remote Australia. The review will be led by nurse, advocate and remote health expert Professor Sabina Knight, as well as senior health bureaucrat and academic Mick Reid. It's going to be underpinned again by extensive stakeholder consultation, with findings expected to be provided to government in the middle of next year. Remaking Medicare for the 21st century is going to take persistent evolution, not revolution. It took 9 years of cuts and neglect to bring Medicare to the weakened state that we inherited, and it's going to take time again to strengthen it. When I stood before the National Press Club on the eve of the May budget, I made a promise and I said, with every gradual foundational change that we make, we're going to put the needs of patients first. And in our first 18 months, we've done exactly that. As we continue to take the hard choices, I fully expect that some will continue to impose some of them. Just like the Liberal Party opposed Chifley's PBS in the 40s, Whitlam's Medibank in the 70s, Hawke's Medicare in the 80s, or our 60-day prescriptions in 2023. And change can be scary because with change comes risk. But the risk of not changing our current system is far greater. We can't keep trying to treat 21st century Australia with 1980s Medicare. So we will listen to all good arguments and evidence about the way forward, but our North Star is and will always be patient benefit. And that means actually listening to patients, which is why we've invested $20 million to support patient voices, including a new body in health for culturally and linguistically diverse Australians, an expanded capacity of the Consumers Health Forum to play their important role, and finally establishing 2 mental health peak bodies, one for consumers and one for carers. Because in a sector that you all know is full of stakeholders with loud voices and sharp elbows, the patient voice has too often been the quietest in these debates, and that needs to change. On the 1st of February next year, as I think Chris said, Medicare turns 40. And just as I'm doing today, in years to come, I'm sure another health minister, maybe Kate, will one day stand before CEDA and chart the reforms of our government. And I know that when they do that, the 2022 election and the years that followed will be seen as an inflection point coming at the end of the COVID pandemic in the history of Medicare. A time when government and the sector work together to right the ship and to navigate through choppy waters and strong headwinds that we face. 5 years from now, I hope that Medicare will be better connected and digitally enabled. It will be delivered by health teams and underpinned by blended funding models, with a strong beating heart of bulk billing, with more workers delivering care in more parts of the country. In short, I hope that 5 years from now, Medicare will be stronger, because that is exactly what the people of Australia elected our government to do. Thank you very much.
Thanks very much. Thanks very much, Minister. Some really insightful pieces of information there, including what the government's agenda looks like on the Medicare front. I was told we were going to have a lot of questions that were going to be ready to go, and they weren't wrong. There are many, and there are some certainly headline popular ones that we'll get stuck straight into. The first one from Dr. Paul Alatheriou from the Nous Group. He asks, you can't manage what you can't measure in healthcare. We need to focus on outcome measures. What outcome measure is top of your mind to ensure that these changes actually make a difference to health?
Well, that's absolutely right. And we had a really good discussion about this within the Strengthening Medicare Task Force about the need to measure outcomes that matter to the community, to patients, but also to health professionals and providers, and ultimately to government as well. And getting the sort of cart before the horse, as we think more about what those measures might be, we need to have a system that actually enables us to measure. I mean, I talked about the lack of engagement with My Health Record by certain sectors of the health community. We're talking, I think everyone in this room understands the lack of good connection between state systems and federal systems. So we miss a lot of what's happening in those diverse systems. And utterly central to the announcements we made in May that didn't get that much attention, alongside things like bulk billing, is our commitment to digital health. When I came back to this portfolio a few years ago and came into government 18 months ago, it really was extraordinary to me how the digital capability of this sector, which is so important to the economy and our society, lagged pretty much every other sector of the economy I can think about. There is not another sector of the economy that performs as poorly, I think, in digital capability as this one. It's the only significant sector of the economy that still underpins the fax machine industry. There's still so much paper in primary care, in hospital systems as well, and where there are digital systems, they're not plugged into each other. It's hard to find really meaningful productivity reforms in a sector like this. This sector, by its nature, doesn't respond well to traditional notions of productivity, but digital health, 60-day scripts, using our existing workforce better, I mean, these are really important measures to drive the productivity of this system, not only in a way that makes it more efficient economically, but it delivers better outcomes for patients. So we are thinking about outcome measures. This is as are most things in health policy, a contested debate within the health sector. A lot of groups of health professionals don't want to see the emergence of league tables and all that sort of thing, so we need to tread through that sensitively. But we also really need to make sure that once we settle upon those things, we can actually measure them, because currently I don't feel as the Health Minister that we have that ability.
Terrific. And you've touched on, in that response, I think answers to a couple of other questions that have been posed.
That was efficient of me. Good
yeah,
productivity measure.
Don't steal all of my questions at the start. And they related primarily to advancements in technology and your commitment to that. I know when we were speaking before lunch, you were very open to taking any question, and thank you for that. And this one probably goes to that preparedness, and it's a payroll tax query. The payroll tax issue is an existential threat to primary care and the government's desire to promote a practice rather than GP-centric model. How are you going to address that?
With difficulty, because we don't do payroll tax at a federal level. I mean, I've spoken publicly about our concern at a Commonwealth level that the very substantial investment into general practice that came out of the May budget, not effectively sort of go through general practice and very quickly end up in state treasury or state tax office systems. I don't think that's what state premiers want, state health ministers want. I mean, they recognise that the priority for our health system right now is primary care, and that the pressure on primary care is showing up every single day at their hospital emergency departments. I mean, that's why premiers are coming to National Cabinet and not just talking about hospital funding, which is usually what state Commonwealth discussions around health policy involve. They're talking about strengthening Medicare because they're seeing the results of a general practice system under such pressure. So it just doesn't make sense to have a federal government invest such substantial amounts into trying to rebuild the sort of financial integrity of general practice, as well as do some meaningful reform, and have that money simply end up in a sort of a changed application of payroll tax arrangements. I think the real pressure on general practice is the idea of retrospective bills. And different states are, I think, having good levels of engagement with their general practice organisations. Queensland's probably the leader in this area, where I think general practice representatives have probably reached an understanding with the state government that they can live with. Gives them time to adjust their arrangements. It removes the threat of being lumped with a several $100,000 tax bill for the last several years, which not many practices are in a position to pay. So what I've said publicly and to the health ministers themselves is we really need a level of uniformity or consistency across the country that reflects a position that states and general practice can live with, that gives general practice time to adjust if there is an adjustment in line with the principles that the New South Wales Supreme Court decision set out. And I think we're sort of edging towards that position. And I'm trying to, from a position that's actually, I don't have a seat at that table, but from the position I'm in as the Federal Health Minister, really trying to encourage states to reach a settlement that ensures that general practice has the confidence that the investments that are coming from the federal government, that by and large state governments have applauded, is actually going to change their businesses for the better.
Thanks, Minister. And we've got a question from the floor. I'm going to deviate off the iPad for a moment. The floor's yours.
Thanks very much. Jane Dallard from Each. Minister, Gough Whitlam opened our first site in Melbourne's eastern suburbs in 1974, and we now care for more than 60,000 disadvantaged and marginalised Australians every year. We recently opened our first Aboriginal GP clinic, and it was co-designed with local elders and members of the community. It's been incredibly successful. We've had people, and particularly old people, coming from as far away as Echuca to visit our tiny little GP clinic in Ringwood. And I guess that's a story about the power of Medicare. But, Minister, one thing that has worried us, that's not about Medicare, is that at a Primary Health Network event here in Melbourne earlier this year, you said, in response to a question from the audience, that non-Aboriginal controlled organisations like ours should be transitioning out of service provision to Aboriginal and Torres Strait Islander communities. But community tells us that they want choice. So we'd love it if you would please clarify your position on this.
Well, all governments are now working to a series of closing the gap agreements that are largely either intergovernmental agreements or they're agreements between governments and the coalition of peaks, which people will be familiar with, which is really the sort of key peak organisations representing Indigenous Australians. And one of those commitments is, can't remember the exact wording, but one of those commitments is to see the transition of services where possible. So it's not a completely uniform. Or, it's not a complete undertaking, but where possible, services for Indigenous Australians be considered to be delivered by organisations run by Indigenous Australians. And the community-controlled health sector for Aboriginal and Torres Strait Islanders is a great example of that working very well. It doesn't mean that Aboriginal and Torres Strait Islanders aren't receiving great care from non-community controlled health organisations. Probably about half of Aboriginal people are not being cared for in the community controlled sector. But there are instances, and we're sort of doing an audit in the Department of Health as part of the commitment that we inherited in that implementation agreement. We're doing an audit of services that are clearly designed for Indigenous Australians, but have not been delivered by Indigenous organisations. And you know, we'll take a case-by-case approach to that. Doesn't mean that funding for every non-Indigenous organisation that's providing care for Indigenous Australians is under threat. By no means at all. We're taking a case-by-case approach. I think the example I might have given at that conference, I've certainly talked about publicly, is the Puggy Hunter Nurses Scholarship Program. And this is named after the founding chair of NACCHO. It's been in place for many years. It's a scholarship program for Indigenous nursing students, but has never been delivered by an Indigenous organisation. And there are, in my view, many Indigenous organisations that more than have the capability to deliver a scholarship program like that. So you know, we've indicated that that program will be transitioned to a tender process over time, open to Indigenous organisations. That is the commitment that all governments have made under the Closing the Gap arrangements. But I don't want it to be seen as a universal approach. We will take a case-by-case approach to this, particularly in primary care. We recognise that there are many, many Indigenous Australians who are choosing to get care and are receiving very good care from non-Indigenous organisations. It's happening in aged care, it's happening in primary care and many other areas as well. But some of the examples, like the one that I just talked about, I think are obvious examples where, where governments, if they are true to the commitments we've made under the Closing the Gap agreements, are going to have to consider a new way.
Thanks, Minister, and thanks for the question. Professor Fells.
Mental health. I wonder if you could give us your take on it. You mentioned the important reform about consultation. Any other comments on mental health, please?
That's a very big question, Alan. Alan was the first chair of our Mental Health Commission when we established it under the Gillard government, so he brings a wealth of understanding and insight into mental health policy that's been a great thing for our country, so thank you for that. Mental health is an area that I'm sort of working with a group on about now. It's not a comprehensive piece of work around mental health. It's particularly a piece of work to respond to the evaluation of the Better Access program, which people might be familiar with. It's a Medicare program to provide Medicare rebates for essentially psychological therapy, mainly by psychologists, but also by OTs and social workers. And I think the evaluation that we received at the end of last year broadly showed what an evaluation I received 10 years earlier when I was the Mental Health Minister showed, which is that for certain cohorts of the population that program was very effective, but its equity was poor. Its socio-economic equity was poor, its geographical equity was poor, and that's not a blinding insight. It's a demand-driven program which effectively led to the creation of a new market of private clinical psychology. Those people decided to set up where they wanted to set up rather than being established in a relatively even way across the community. So we find, in spite of the fact that the poorest quintile of Australians have much higher levels of mental distress than the richest quintile, they're getting far less service from a program like this than the richest quintile is. And this has been an endemic challenge in this program. So we're working through a whole range of sort of questions. How do we get better equity in the system? How do we deal with what Pat McGorry and others have described as the missing middle, which, as we've seen, mental health levels of mental health grow almost inexorably over the last 20 years or so. We've also seen an increase in complexity and severity for the broader population and particularly for the young, and we don't have good systems for that. We've developed, I think, good primary care systems for mild to moderate mental illness. They've got waiting lists, they're a bit overwhelmed by demand, but they're good models of care. The state systems really have retreated to the most acute need, and there's this big gap in the middle. So we're looking at that. We're struggling, as so many areas of health are, we're struggling with a shortage of workers. There's a shortage of psychologists, so we're trying to expand that workforce through a range of measures in the May budget. But we're still really trying to sort of struggle through how we redesign this program that's pretty basic. It's demand driven. It doesn't have a lot of levers to target it more to people with complex and severe needs. And its workforce is pretty poorly distributed through the community. So to be blunt, we've sort of got more work to do. We've got a great group working with me, and I'm working directly with them. I'm chairing those meetings. We've got a full day meeting on Thursday, for example, to continue this work. But it is something, that cohort of sort of that missing middle is a real gap in the system, and we're having trouble designing how we'd fill that gap and thinking about how we'd get that workforce into the right places.
Thanks, Minister. We've got a few themes that I do just want to get through here, and then we'll throw to a question at the back of the room as well, starting with chronic disease and then hospital admissions, and we'll go to the question at the back of the room. The current Medicare structure based on fee-for-service doesn't encourage or support preventative activity. With a chronic disease epidemic, how will we change the structure of funding to support this?
Well, I talked a bit about the MyMedicare system in my remarks, and about two cohorts that we've identified as early targets for registration and with a general practice, and for blended funding models. And I think ultimately, as this builds, there are cohorts of people with chronic disease that would really are obvious targets for that sort of a system. And there are plenty of pilots that have happened over the last 20 years. We had a diabetes care pilot that evaluated pretty well, actually, for diabetes type 2 patients. Didn't really go anywhere, and there have been others as well that have been fixed term with mixed results. I mean, my real ambition here with the MyMedicare system is to build it not slowly but steadily. I've seen, and many in this room will have seen, so many attempts to create this sort of more wraparound system with blended funding. Sometimes they perform well, sometimes they don't. The common thing, though, is that they're all terminated, and they don't actually build structural reform into the system, and that's what I want to do with MyMedicare. So the sort of so-called frequent flyers in the hospital system, that 13,000 or so people who might present at an ED more than 10 times in a year, sort of quite a small group, complex group, but we think we can really demonstrate some great outcomes through that, along with the aged care group, and hopefully build confidence in the system, in the health sector itself, as well as among patients, that having confidence in this idea of registration, of a real, genuine relationship between patient and practice, and some blended funding models that are targeted to real outcomes, is something that we want to embark on, not just for another pilot, but for the long term. And I think Australians with chronic disease are really the obvious group that we'd target there. They're not the only group. I also have in mind a real ambition to see this type of care move into the first 2,000 days, and whether there are ways in which we can build that sort of a system that works well with child and maternal nurses in state systems, works well with the early years strategy that Amanda Rishworth is building as well. But I just really want to emphasise that, having watched this over the last 20 years, it would be an absolute tragedy if we tried this and in 3 years some government just said, nah, and doctors' groups weren't interested in it, and it was just another pilot that might have evaluated well but didn't lead to real structural reform in the system.
Thanks, Minister. Going to hospital admissions now. With secondary care funded by the states and primary care by the federal government, how do you create a system to support better health outcomes and reduce hospital admissions? Well,
when I was last in the health portfolio, people might remember Kevin was going to fix hospitals, and there was a very long, pretty tortuous process of health reform discussion, all between Labor governments. The whole country was Labor. So it wasn't because we didn't have sort of a level of party political unanimity, but it all fell apart. And there was, you know, my experience, to be blunt about it, of that time, was that there was a real sense of my trench, your trench, and a lack of willingness to see the two systems connected. And it might be those demographic changes that I talked about in my speech a bit, but I think more because of COVID and the way in which we had to work together, there's now a much greater level of trust and a real willingness to, for example, to build a genuinely interconnected digital health system. I mean, Sydney, through the Lumos project, probably did the best trial of that and demonstrated some really good outcomes, both for hospitals, for primary care, but most importantly for patients. And I think we've looked at that really closely through strengthening Medicare. We've looked at it as a group of health ministers as well. So I think digital health is the key to really connecting our two systems much better. The other reason beyond that group of 13,000 frequent flyers in the hospitals being the best first cohort, the other reason beyond the obvious, which is that they're some of the most complex, vulnerable, in-need Australians we have in our community, the other benefit is it's only going to work if we get states to buy in. So what state LHNs are going to have to do is they're going to have to identify who they are in the first place. They're then going to have to work through PHNs with identified general practices who are willing to register them, take on blended funding and some incentive payments, and LHNs will have to be helping us report whether we actually see reduced hospital admissions, which is obviously going to be the key KPI about whether this particular program works. So again, it's not just, I talked a bit about building confidence among our primary care workforce, particularly GPs and patients. We also want to build confidence with state governments and LHNs that by working together on these things, we can get a real sort of win-win in both parts of the system, rather than it being that trench warfare that has characterised most of the history of intergovernmental relations on health.
Yeah, intriguing. Question at the back, please.
Thank you. My name is Tony Scott. I'm Director of the Centre for Health Economics at Monash University. I guess it's a very ambitious and comprehensive reform agenda. How do you know whether it will work, and will you be investing in evaluation and research to, in the longer term, to kind of show that this stuff is going to really impact on Australians? Thank you.
Great question, the sort of question I'd expect from Monash, so thank you for that. We put, I can't remember what it was, but quite substantial funds aside in the May budget for precisely that purpose. The task force said exactly that to me. They said, this is all well and good, how are we going to know whether it's working? We had people like Stephen Duckett on the task force who was banging that drum repeatedly, and I think it's absolutely right. So we're now in the process of building that group who will oversee that work with the department, including independent evaluation. There are funds available for that. It's pretty early days, but we're committed to doing that work and reporting on it as well. One of the other things I found, again, when I came back into the portfolio, is that the sort of research effort in primary care had dropped off. Some of the structured primary care health and medical research that I was familiar with when I was last in government, had responsibility for the NHMRC over a number of years, had finished. Some of it, you'd know the schemes that were in place that have largely gone. So we also funded very recently a new mission through the MRFF for primary care research itself, because we want to build a sense among, well, first of all, we want to see what works, obviously, but another motivation of mine through all of this the way in which I try to talk about general practice, the prominence I've tried to give to strengthening Medicare, and particularly the general practice elements or the primary care elements of that, above all of the other things happening in health, is to rebuild the status of primary care. It's not only sort of working out what works, it's, you invest in what matters. And too often we see primary care and general practice is the thing that falls off the edge of the table first. I'd heard through COVID, as universities were under pressure, some universities, the first thing that went in their medical school was the chair in general practice. At a point where we have fewer medical graduates choosing general practice as their career than we've ever had. So part of this is about status. It's about culture within the health sector, within the medical profession itself, as much as it is about measuring what matters and being very open and transparent with those outcomes.
Thanks, Minister. I'm just going to close with one question. It picks up a couple of themes that have come through, and it's probably not unique to the healthcare sector. It relates to workforce demands and shortages of expected workforces. One statistic that's come through is a 30% deficit of doctors by 2030. What's the government's plans to address this shortage of healthcare professionals to ensure a robust workforce to meet increasing demands on the healthcare sector?
First of all, can I say some of you will know Blair Comley has just taken over as the Secretary of our federal department, and Blair likes numbers, which is a terrific thing to have as the Secretary of your health department. And he's commissioned some really detailed work ourselves on workforce demand into the future, and we'll be rolling that out in the very near future. So we're crunching our own numbers. They are going to they might end up being slightly different numbers to some of the work that is getting around a fair bit, that I think Deloitte might have led pretty, but I can't quite remember. But we might quibble on the precise number, but there is going to be, there clearly is a shortage, particularly when you adjust for age and the trajectories on chronic disease. So the focus right now is to do what we can in the relatively short term, because like pretty much every country in the developed world, we're facing a very serious workforce crunch right now, and the only way really you can shift the dial in the short term is overseas recruitment. And so we had Robin Cruck, a very esteemed long-term health bureaucrat, do work which was actually commissioned by the Prime Minister and Premiers to try and streamline the way in which we bring overseas health professionals in from other countries. Very clunky system. I said on Melbourne radio this morning, I think we've for too long relied on this being a terrific country, and why wouldn't people choose Australia instead of the UK or Canada to work in? Well, they've really lifted their game. They're sort of the aggressiveness of their marketing in an increasingly competitive short market for international nurses and doctors in particular has left us napping a little bit, I think. And so Robin's report really pushes us to lift our game. In migration areas, so visa processing times, I think we've already got them down very considerably, but some of the regulatory burden, I think, that should be relatively easy to clear is a real problem for practices that want to bring people in, state governments that want to bring people in. Often we get someone into Sydney or Melbourne and they sit in an apartment or work at a cafe for months because we can't get them onto the floor. Frankly, I think we're going to have a bit of a look at some of the college systems around the recognition of competent authority pathways. Now, that's not going to be easy. But we do want to really try and clear that. The scope of practice review, I think, is going to be really important. I mean, I think one of the clear productivity challenges we have in the health sector here is that we have, what we would have called when I started in the union movement more than 30 years ago, demarcation arrangements that just don't exist in any other sector. I remember them in the 80s and 90s in factories. They don't exist anymore. We have a whole bunch of people, I mentioned nurses and nurse practitioners, but a whole bunch of people in the health workforce who have these artificial constraints on what they can do that have nothing to do with their skills and their training and their experience, but are just the way we've done things. What they mean is that we deploy our health resources in an incredibly inefficient way, and at a time where demand is going like that and supply is constrained, the idea of not having every single health worker operating to the top of their scope, the top of their full extent of their skills and experience, is a terrible return on investment. When you think about it this way, we spend billions educating our health workforce, and it's really not doing the right thing by patients as well. So there's some of the short-term things. I think as this modelling for 2030 and beyond comes out, it is going to start a debate about the training of a domestic workforce and whether we've got those numbers right broadly. And within those numbers, whether we've got the distribution of specialties right between some of the consultant specialties, particularly general practice and psychiatry, on the one hand, and the procedural specialties on the other. But we're not quite at that point yet, and we can talk about that at another CEDA lunch. Thank you very much.
Thank you. Some very challenging short-term obstacles to meet, not just here but abroad. Thank you, Minister, for your openness and informative responses to many of the questions, a lot of which we haven't been able to get to, but thank you very much.
Thank you. Thank you, everyone.
Well, what a great discussion. You've left us with plenty to think about, including impacts on ageing population, how important it is having the breadth of thought leadership and perspectives in the room, the skills and workforce shortages that you've just mentioned, and the health workforce crunch, which was a hot topic at our migration forum in Sydney yesterday, the role of technology and digital capability, and mental health on its impacts socially and economically. These are all topics that CEDA is intimately invested in, and we'll continue to monitor developments, and we look forward to continuing to engage with you and our members throughout the year. And of course, like Blair, CEDA loves numbers. I'd like again to thank our participants today, the Honourable Mark Butler MP, Minister for Health and Aged Care. Thank you to Chris Carroll and Matt Callagher and our sponsors Bupa and Clayton Utes. Your ongoing support allows CEDA to continue and contribute to the discussion on key policy issues. Thank you. Now, it would be remiss of me not to mention our upcoming CEDA events. If you've enjoyed the event today, and if you haven't had enough of CEDA and you need another event in your pre-Christmas calendar, please jump onto CEDA's website and check out our events coming up across the country and on live stream before the end of the year. On Wednesday the 13th of December here in Melbourne, the Honourable Bill Shorten will speak on the future of the NDIS, and further afield on the 8th of December we're collaborating with CSIRO to present at the AR Leadership Summit, a lineup that is absolutely not to be missed. Please check it out. And if you're a forward planner, early next year on the 22nd of February, our Economic and Policy Outlook is here in Melbourne, where the Chair-elect of the Productivity Commission, Danielle Wood, and Stanford University and leading figure on hybrid working, Professor Nicholas Bloom, will speak. Thank you again for joining us at today's event. We trust you found it to be a valuable discussion. Please make the most of the connections you've made today, and we look forward to seeing you again soon. Thank you.